Today, I am revising your functional areas. Because during the class, I will tell you one thing, the disease from which most of the students are suffering. Out of 260 students, 180 students are suffering from that disease. That I will talk later on. Okay. Functional areas. As we remember, the brain is dividing into for three functions: sensory function, motor function, and association areas. Motor areas, they are present anterior in the frontal lobe. In the frontal lobe, the sulci are the central sulcus. Anterior to the central sulcus, there is the precentral sulcus. The area between them is the motor area. Just anterior to that, there is the sensory motor areas, area number 6 and 8. They are lying anterior to the precentral sulcus, or you can say just posterior to the superior frontal gyrus, middle frontal gyrus, and inferior frontal gyrus. That things we had talked yesterday. You can see this is the central sulcus, and area number 6 and area number 8, they are actually the 6th area is the perfect premotor area, because area number 8 we are considered that for the frontal eye field. Okay. Just anterior to this, that is prefrontal area. The prefrontal area including the area number 9, 10, 11 and 12. This area, prefrontal area, is connecting with the limbic system. आपका गया क्या प्रीफ्रंटल एरिया? आई एम टेलिंग यू बॉय, आप उधर मत देखिए, आपको ही कह रहा हूं मैं. यस, वाई आर यू टॉकिंग कंटिन्यूसली? प्रीफ्रंटल लोब तो लोबेक्टोमी नहीं करवा ली? सिट डाउन. Then just see posterior part of the central sulcus, that is this one. This is the post-central sulcus, and the area or the gyri present between these two, that is the sensory gyrus, or area number 4, 3, sorry, the area number 321, that is the primary sensory area, that is this one. Just posterior to this, what is this lobe? Parietal lobe. So, a parietal lobe, if you remember, that is dividing into the superior parietal lobe, inferior parietal lobe by the transverse parietal sulcus. Here, you will find that the diagram is showing the area number 5 and 7. This is the superolateral surface. Area number 5 and 7. These are the secondary or association sensory area. Lower down, this is the lateral sulcus, posterior ramus of the lateral sulcus, and below this, that is the part of temporal lobe. In the temporal lobe, again you can see the two sulci, superior temporal sulcus and inferior temporal sulcus, which divide this into three parts: superior temporal gyrus, middle and inferior temporal gyrus. All right. Now, look here, just below this part, that is, this is the terminal end of the posterior ramus. Here is the diagram is not showing. There is present the area number 23. that is taste sensation, that I will talk. And lower down, you are seeing here, there is the area number 41 and 42, auditory area, primary auditory area. And below this primary auditory area, there is the area number 22. This posterior ramus of lateral sulcus extending in the lower part of or inferior parietal lobule. And similarly, the superior temporal sulcus is also extending in the posterior part or inferior temporal gyrus. So, here you can see the area number 39 and 40. On the dominant hemisphere, it is showing the part of Wernicke's sensory area. Wernicke's sensory area. And in the posterior part, this is the occipital lobe. You can see the imaginary line. This is the first imaginary line. The second imaginary line is not shown. The first imaginary line, which is extending from parieto-occipital sulcus in the superior-medial border downward pre-occipital notch. So this is the occipital lobe. Occipital lobe is showing the three areas. The primary visual area, the area number 17, and just above it you can see the peristriate area and parastriate area, that is area number 18 and 19. These are the association visual area. Both simple, no problem. Then on the medial surface, if we see, look here, that area number 24, 23 and 28 is here on the uncus part. What is this? This is the corpus callosum. Above the corpus callosum, there is the sulcus, callosal sulcus, and this is the cingulate sulcus. So, area which are showing 23, 24, this is the cingulate gyrus. This cingulate gyrus and this parahippocampal gyrus, and the part uncus is also the hook-shaped part of the parahippocampal gyrus. This completely connecting with the limbic system, and it is related with the olfactive sensation of the body. The smell and olfactions, they are concerning with the limbic system. All right, this is the prefrontal area, 9, 10, 11, this part. And look here, the area number 6, what is this? This is central sulcus extending here on the medial surface, and it is surrounding by the gyrus, that is paracentral lobule. Paracentral lobule. All right. Now look here. The area number 4 is coming on this side, and this is the 312 sensory area. Sorry, the 6 and 7, that is the part of secondary sensation area. And this is the medial surface of calcarine sulcus. Lying over the calcarine sulcus, the area number 17, and above that the area number 18, 19 and this. All these are the functional areas of the brain. Now let's see, besides this, the motor speech area, Broca's area and Wernicke's sensory speech area, they are present only on the dominant hemisphere. They are present only on the dominant hemisphere. So don't speak on both the lobe. समझ में आ गया? Only they are present on the dominant hemisphere. The motor function, if we stimulate or give the electric stimulation to the area number 4, it will result into contraction of the skeletal muscle of the opposite side of the body. But listen carefully. This contraction of skeletal muscles on the opposite side of the body is not phase, not head and neck, only in the limbs and trunk region. Why? Answer, listen, answer. You have gone through the tracks and everything, but not replying me. The answer is limbs, trunk, they are supplied by the corticospinal fibers. Corticospinal fibers. So if I stimulate the right side of the area number 4, there will be the contraction of the muscles of upper limb, lower limb and trunk, but not of the face and head and neck region. Answer is the upper part of the head and neck and face, they are supplied by the corticonuclear fibers. Corticonuclear fibers, that is the projection fibers which are terminate at the nuclei of the cranial nerves. Okay, and the nuclei of the cranial nerve is receiving the bilateral nerve supply. Cranial nerve nuclei are receiving the bilateral nerve supply. तो एक साइड अगर आपका इफेक्ट नहीं कर रहा है तो it will continue. The same thing happened in the nerve injury of area number 4, maybe because of nerve injury or disease. If area number 4 is affected, that will result into hemiplegia. Half of the body is paralyzed. Half of the body is paralyzed. The same thing applied here. When you become doctor, don't see the head and neck and face. If the patient will come hemiplegia, he will or she will complain of paralysis of the upper limb, lower limb and trunk, but his face and head and neck is normal. That clearly indicates that is hemiplegia. And why the upper parts is sapped, that I have told you. That is supplied by corticonuclear fibers. The nuclei of the cranial nerves are supplied by both the sides. That is one thing. Another thing, that there is the motor area and premotor area. What is the necessity of premotor area? Look here. This is area number 4. Area number 4 is responsible for control of the skeletal muscle contraction. The area number 6, premotor area, it gives the information to the area number 4 that how much contraction you require and which part of the limb. On the past experience, the area number 6 give the information to area number 4 that you require the contraction of the muscle too much or which part of the limb you require the contraction. That is the function of area number 6. Area number 8, that is frontal eye field. Stimulation of area number 8 will cause contraction of opposite direction of the two eyes. It controls the conjugate movements of the eyeball. Area number 8, frontal eye field, it controls the conjugate movement of the two eyes. Then we come to the part of area number 44 and 45. On dominant hemisphere, this is called Broca's area or motor speech area. The motor speech area, it generates the sensation. It generates the sensation to act the larynx, for the action of the larynx, the palate, lips, tongue and lower jaw. The generation provided by the stimulation of Broca's area. When we speak, the generation impulses are coming from the Broca's area. Understand? When we try to speak or continuously speaking, the generation the impulses are coming from the Broca's area, and these Broca's area impulses, they stimulate the larynx and the hard palate, the palate, larynx, lips, tongue, and lower jaw movement. So all these movements are started by the stimulation or by the general sensation coming from the Broca's area. Now, if you understand this point, motor aphasia, that is the condition in which when we use the word aphasia, that means person is not able to speak. This can be the sensory aphasia or can be the motor aphasia. Now what happens? In motor aphasia, the point is that there is a disease or injury at the Broca's area. Understand? There is the injuries of Broca's area. So because of that, the sensations are not coming. No doubt, the patient larynx, lips, tongue, everything is normal. Everything is normal. But still, the patient is not able to speak. Very simple, because there is no impulses coming from the Broca's area to stimulate these parts. And the person who is suffering from motor aphasia can understand, very important thing I am telling you, the person suffering from the motor aphasia can understand the written speech, also the spoken speech, written, everything they can understand. And the person suffering from motor aphasia can write or explain the thing by writing, because he is understanding the each spoken words, written words. So he cannot speak. So instead of speaking, he can write or explain the thing, what is going on. Understand? Opposite to this, there is the sensory aphasia. देखना यार किसकी बीमारी है, बंद करो. Opposite this, the sensory aphasia, in which there is the lesion of area number 39 and 40, and the person is not able to speak, and also is not able to understand the written words and spoken words. That is the disease commonly occur the students during the exam. Am I right? That is the disease commonly affected the students during the biopsy time. Maybe someone during the class also. That is, due to this lesion, the patient is not understand the written words nor the spoken words. So they cannot write. क्या लिखेगा? इसलिए don't sit idle in the class. And this sensory aphasia, so the difference between sensory aphasia and motor aphasia is that in case of motor aphasia, the patient understands the written and spoken words, so they can explain by writing. But the patient who is suffering from sensory aphasia cannot explain, because he or she is unable to understand the spoken words and written words. Okay, clear? Now, after this, another part which I want to tell you, the primary sensory area, area number 321. This area is receiving the general somatic sensation. Listen carefully. This area is listen general somatic sensation. General somatic sensations are pain, touch, temperature. So pain, touch, temperature sensations are going to the primary somatic sensory area of the complete body. All right. Then the area number 5 and 7, somatic sensory area. These areas, similar to the secondary motor area, on the basis of past experience, they analyze and integrate how much pain is coming, why the pain is this, and what type of the pain can come from touching by which part or like that. That means on the basis of past experience, the 5 and 7, they analyze and integrate, and that integration is passed to the area number 312. That is the function of 5 and 7. बहुत सीधी बात बता रहा हूँ मैडम, इतनी परेशान मत हो, आपसे कह रहा हूँ. What you understand about the area number 5 and 7? बोलो, बड़े खड़े होके बोलो. They analyze, right? If this type of pain is coming from which part, touching by which part, or which area I am standing here. That all on the past experience they analyze, and after analysis integration they pass this sensation to the primary sensory area. Besides this, there are the other sensation area, and these sensory areas are association areas are with the part of vision area. Look, the vision area, that is primary visual area, is 17, area number 70. When we see the person or any object previously, right? When we are seeing the second time that person or the object, so the first time when we are seeing, the sensation reach to the area number 70. पहली बार आप देखते हो, that sensation pass to the visual sensory area, primary visual area 70. Okay. Second time when we are seeing that, then the area number 18 and 19 act. They analyze that you have seen that person and that is that person. All the things they evaluate. Name of the person, sex of the person, and all that thing. Even then you can also narrate what he is doing, what is he. The same thing. All these things, they are generated by the secondary or association visual areas, that is 18 and 19, and that sensation passed to the area number 17. That means whatever the things we are seeing, that is coming first of all to the area number 70, and area number 18 and 19 on the past experience, they analyze, identifying, all the things are done by these area number 18 and 19. So that is the function of area number 17, 18 and 19. So identification is done by the past experience of 18 and 19. Now come to the part of 13, 19, 40. I have told you. In the region of, this is the sensory area, in the terminal end of it, just above the area number 41 and 42, or you can say just above the posterior MS of the lateral sulcus in sensory area. It is related with the taste area. Taste area 43, that is here, it is present. That is not so important. The important part, look here, the area number 41 and 42 and area number 22. No doubt, The area number 22 is named as the sensory auditory area. Sensory auditory area. The primary auditory area is 41, 42. And if there is the injury or disease of the 41 and 42 area, the patient is complaining of loss of hearing, not completely. Loss of hearing, but loss of hearing is not complete. The reason is because the other part is working. Understand? The loss of hearing is not complete. The other part is working. And what are you hearing? The area number 22, that is association area. आप गाने सुनते हो, when you are listening music, on just listening the music or song, you can select or you can differentiate that this song is from this movie and who were singing. So all these things are done by the area number 22. That is association area. The same thing, when we listen the sound, by listening the sound, we can appreciate that this is the sound of that. All these things are done by the area number 22. 41 and 42, they are mainly responsible for hearing. And the lesion of one side is not completely loss of hearing, partial loss of the hearing. Then we come to the part of olfactive part. The olfactive part, that is area number part is 28, 24, 23. The 24, 23, they are present in parahippocampal gyrus, and 28 is present in primary uncus part. So uncus and parahippocampal gyrus, cingulate gyrus, all these parts, they are related with the limbic system. They are related with the limbic system. So, and you have already read that olfactive tract, it is not reaching through the thalamus, it is reaching directly. So, they are concerning with the smell and other part of limbic system that we will talk separately in the limbic system. Then look the prefrontal area, 9, 10, 11. The prefrontal area in normal person, listen carefully, in normal person the prefrontal area is generating frustration, tension, anxiety. All these things are generated from the prefrontal area. हटा दें इसको. There is no problem, no anxiety, no tension, right? And this area is also related with the limbic system. So because of that, it is also responsible for the personality behavior of the person. So area number 9, 10, 11, prefrontal area is responsible in normal person for all these things. On the lesion of this area, and it is also concerning for the recent memory. Recent memory and intelligence is also related to this. So no one wants to remove this. Understand? It is also related with the recent memory and the behavior and all that thing, and judgment. Whenever there is injury of this area, that result, the person becomes not concerning with the social behavior, becomes rude, and also not concerned, no tension, no anxiety. Everything is there. is least bothered about social behavior and everything. He himself thinks that rude becomes rude and not concerning with the social behavior. Who is suffering was least bothered. All these things result. But still, his intelligence is remained. There is no effect over memory, no intelligence is lost. Everything disappears. Tension, anxiety, everything disappears. Becomes rude, careless, lethargic. But still is अभी मत इससे शुरू बाद में कर लेना. But still his intelligence and memory remain same, no effect. That is all occurring in case of bilateral involvement of the prefrontal area. The reason how it can be lost most commonly because of tumor of the prefrontal area. If there is a tumor of prefrontal area or the injury, that can cause all these things. Now look this diagram, how the representation on the part of central, precentral area and postcentral area. The representation of the body is upside down. The foot part is above, then leg, trunk, shoulder, hand, thumb, neck, and like this. This is called upside down representation. Upside down representation. And it is not concerned with the area of the body. Look here, the leg, such a small representation, foot and trunk, shoulder like this. But as the hands are most commonly used in skill movements and this thing, it has the large area of representation. Thumb and same part of the lips and like this. So this is the representation over this part. One thing, how the projection, the areas which fibers which are coming from the motor area, area number 4. These fibers, they descending down over the body by the 3 ways. They can reach to the anterior horn cell of the spinal cord. These fibers which are coming from the cortex, cerebral cortex and reaching to the anterior horn of the spinal cord, these are named as corticospinal fibers. Corticospinal fibers. Besides this, these projection fibers also reaching to the nuclei of the cranial nerves. These type of projection fibers are called corticonuclear fibers. And thirdly, the fibers which are arising from the cortex and reaching to the reticular formation, these are named as cortico-reticular fibers. So these are the 3 ways by which the projection fibers reaching to the different parts. And how they reach? They first of all, they comes out from the cerebral cortex and they come to the internal capsule. We have not gone through the internal capsule, that we will talk. Look the diagram. This is the part, white fibers which are present between these structures. On the lateral side, this is the lentiform nucleus, and this is the caudate nucleus, and this is the thalamus. Between these, you are seeing this part, that is the internal capsule. So internal capsules on the lateral side is formed, the ball on the lateral side is formed by the lentiform nucleus, on the medial side by the head of caudate nucleus and thalamus. So projection fibers, they run through these internal capsules and coming out from the internal capsules, and they are reaching to the different parts. Here the diagram will show the medial geniculate body and lateral geniculate body. Medial geniculate body is concerning with the auditory sensations. Lateral geniculate body is concerning with the vision. And you can see here the auditory radiations, and that I will not tell you at present. The optic radiations, they are passing downwards. So after coming through the internal capsule, these fibers, they reach to the part of midbrain, and from that they pass through the crus cerebri, and lastly they are reaching to the part of anterior nucleus of the spinal cord. So that is the way how the projection fibers reaching to the different parts of the body. Similarly, the sensory, all the sensations from different parts of the body, maybe it is general somatic sensation or maybe the special sensation, they also reach to the brain through the thalamus, except the olfactory, and they reach the thalamus, and from the thalamus they pass to the cerebral cortex. Okay, so that is complete part of the cerebrum. As I told you previously, the cerebrum covered by the cerebral cortex, that is called gray matter, and below the gray matter, inside there is the white matter. Lying in the white matter, there are the masses of gray matter, and these masses of gray matter are all these. They are the visual ganglia. The white fibers are of three types. You can see here. This is the corpus callosum. The white fibers can be association fibers, projection fibers, or commissural fibers. The corpus callosum is the example of commissural fibers, and it is having the different parts: genu, rostrum, the body, and splenium. And lower down, this is the fornix, and this is the septum pellucidum. I think that two batches remain. Today I will show you over the cadaver. Right? All these parts: corpus callosum, septum pellucidum, and this lamina terminalis, and all that I will show you today. The batch number C and D. Don't worry. Okay? So that is all the part of white fibers and this. चलो हो गया टाइम.